One is slow VOR, and that's just moving the patient's head side to side, looking for their eyes to stay on your nose. And yeah, that's what I was just talking about. You're taking that information and helping your eyes to stay focused while your head is moving. And then the other is like a fast impulse. And for the head impulse test, you move quickly and randomly, so you're not telling the patient which way you're going to go, and you shouldn't be giving it away because it should be random. Very small distance. You're not trying to get a pop or cavitation. This is not that. But again, seeing if their eyes can stay on your nose with that one. So the direction you turn their head is the side that you're testing. So a right thrust, right, would test your right ear. A left thrust would test the patient's left ear. So, all right. I'm just going to place my hands on either side of your head. I'm going to tilt your head down about 30 degrees. You can look at my nose. And then we're just going to slowly go side to side here. And she's staying focused on my nose.
I'm supposed to, right?
Mm-hmm.
Okay.
And then I'm going to kind of add in some fast movements. Your goal is the same. You're still just going to stay focused on my nose here.
Okay.
Perfect. So, yeah, test is done so fast that you can't think about it and use smooth pursuit. That's why it's a reflexive test. That's why you have to be that fast. If you do it kind of like, then their eyes can just like look. You can just look and you can get a false negative that way. But it's done because it's subcortical. It's just happening at like a very quick response. And if an abnormal sign for this one is if their eyes go with their head to the side, and then they have to use a corrective saccade to get back to your nose. So, if, again, I'll show everybody. If I'm the patient, my head is thrusted this way, or to my right, if my eyes go, that would be a positive test, and that would be a positive test for a right vestibular hypofunction, a right unilateral vestibular hypofunction. Yeah. So.
Wait, why do you call it hypo? Like, how do you know that term? Like, hypo.
It's working. That's what the diagnosis is.
Oh.
So all it means is that vestibular nerve, the vestibular branch of your vestibulocochlear nerve, is degraded to some degree.
Oh, that makes sense. Okay.
Yeah, because they're not very creative in vestibular language, which is probably a good thing. Like VOR and VOR cancellation. Hypofunction just means functioning less. So, which is different, which is basically our PT diagnosis, which is different than a medical diagnosis, which is like a vestibular neuritis, vestibular labyrinthitis, Meniere's disease, like all these different things that the person could be causing the hypofunction. So, yeah. Have you guys heard the terms vestibular neuritis or vestibular labyrinthitis?
Mm-hmm. Neuritis, not the other one.
Okay. So,
Topic 3.
our eighth cranial nerve is our vestibulocochlear nerve. It's one nerve that runs that is hearing, your cochlear nerve and your vestibular nerve together. It then splits into two. The cochlear nerve goes to your cochlea, and that's basically your hearing function right there. So, and the vestibular nerve goes to your semicircular canals, and that's basically your balance and equilibrium function on that side. So if just that vestibular nerve gets inflamed from whatever process, stomach flu, COVID, whatever thing, ear infection, then that is a vestibular neuritis. The patient is just going to have this dizziness problem and a hypofunction on that side. if both arms of that nerve, vestibular and cochlear, get affected, that's called the vestibular labyrinthitis, meaning the whole labyrinth is inflamed, and that person's gonna have hearing problems as well. They're gonna have like tinnitus, they're gonna have like decreased hearing function, and that's kind of an emergent problem because whatever hearing problems they've lost probably aren't gonna get back, and that person needs steroids pretty quickly. That's
that
like
from
go
an
to the
ear
emergency department. I'm
Is
sorry?
it from like having an ear infection that's not being treated, or like how do you get to
Could
that
be a
point?
systemic thing, so people get like sepsis or something, or they have COVID, I keep using that as an example, or they have a stomach virus or something like that, like anything that would cause inflammation in your body. People get it with MS because there's already like, they're so easily inflamed with things, you know, like, but then basically they'll either gonna do oral steroids or a steroid injection in their ear, which will stop the hearing loss in its tracks, but then whatever they lost is probably gone and not gonna come back. So if you're just like, if you don't see that and send them for that right away, then they can even lose more hearing that they've already lost and become deaf on that side. So fairly important distinction between the two.
Is soreness ear not as severe to cause something like that?
It can. Anything, like literally like anything. There's something called a cholesteatoma, which is like a pseudo tumor of like gross stuff in your ear, like dead skin and wax and stuff, and it makes a tumor, and that can cause problems. You know, like there's anything that can like make that area angry can cause these problems. So, yes.
Can you do that again?
The test on here.
No, you said the abnormal. You said it would be abnormal if you turn to the right.
Yeah.
Can you show
I definitely will, and then I'll also, when we break out, I'll pull up a video of a real person's positive test. So if I'm your patient and you thrust my head that way, and my head goes, or my eyes do that, then that's a positive test to my right hypofunction. If you thrust my head that way and my eyes stay on your nose the whole time, that's normal. That's what we want to see. So it'll either have a right hypofunction, a left hypofunction, bilateral, or nothing at all. Questions about that one? About those two? Okay.